Bismillah ar-Rahman ar-Rahim. Good day, everyone. I'm Dr. Mahmoud Sheikh, a nephrology learner. Today's lecture is titled as Decoding Acid-Based Disturbances from Bedside to Exam Hall. We will dive into the complexity of acid-based disorders, exploring their metabolic and toxic iatrogenic causes, and connect these concepts to clinical, critical care, and emergency scenarios. Let's make these complex topics clear and practical, both for your patients and your exams. We'll begin with a look on MDMA, also known as 3,4-methylene dioxymethamphetamine, and its abuse. Sometimes it's called meth or the blue candy, as popularized by the American series Breaking Bad. Starting with pathophysiology, this is commonly consumed at rave parties for energy and empathy and euphoria, and it promotes excessive thirst, polydipsia with increased ADH release. ADH will decrease GI motility with impaired water absorption. Large volume of this retained fluid in GI tract with sudden absorption lead to severe dilutional hyponatremia and also cause transient high ion gap metabolic acidosis to lactic acid accumulation. Also, it can induce non-traumatic rhabdomyolysis with muscle breakdown. Patient will come with decreased serum sodium and osmolality due to dilution effect and this true hyponatremia, with elevated urine sodium excretion, sometimes tachycardia, maybe if severe enough to pulmonary edema, seizures from cerebral edema, and elevated CPK from muscle damage, rhabdomyolysis in severe cases with AKI. Sometimes in reported cases, drug-induced liver cell failure and vasculitis. Ecstasy toxicity present with characteristic triad of hyponatremia and transient lactic acidosis with altered mental status. The acidosis typically resolve within hours, but may be a precursor to more severe complications, including cerebral edema, seizures, and multiple organ failure. The management to focus on supportive care and correcting life-threatening complications. Hyponatremia, often due to cyanide and excessive water intake, should be managed according to the severity. For example, mild or asymptomatic cases with fluid restriction could be managed, while severe or symptomatic hyponatremia, like presence of seizures, coma, requires cautious administration of hypertonic 3% saline to avoid rapid corrections or osmotic demyelination syndrome. Metabolic acidosis, usually lactic from hyperthermia or agitation or seizures, by addressing the underlying cause. Cooling for hyperthermia, for example, benzodiazepine for agitations or seizures, or anti-epileptic medications with adequate oxygenation and perfusion with good IV fluids. Serum bicarbonate may be considered if acidosis is severe enough, like pH less than 7.1, or concomitant complications such as arrhythmias or the presence of rhabdomyolysis. Continuous monitoring in ICU setting is recommended for severe cases such as in convulsion or cerebral edema, as we mentioned, or in presence of multiple organ failure. Shifting to another entity called EIH, exercise-induced hyponatremia, or also known as post-marathon agitation. Starting with pathophysiology, excessive fluid intake during prolonged physical exertion, continued drinking, despite ADH stimulation, as we know, all that ADH stimulated by nausea, vomiting, stress conditions, pain, maybe anesthesia, post-surgical pregnancy, many stimulators for ADH. In stress conditions or exercise will be stimulated, so the presence of this stimulation with continuous drinking will, with also the effect of ADH, as we mentioned before, in delayed gastric absorption of ingested water, unit size, all of this will will be followed by sudden absorption of accumulated fluid post-exercise, will be a cause for the diluted sodium with true hyponatremia. The impaired renal free water clearance during exercise also, plus sodium losses through sweat, contribute to this hyponatremia. Risk factors and the clinical presentation, which is very important in clinical practice and also in MSQ. Sometimes they ask about the risk factors. The female patient more predisposing for that. Insufficient training status or conditioning, exercise duration exceeds 4 hours, low sweating rates despite physical exertion, cool weather conditions decreasing thirst sensation, weight gain paradoxically observed despite exercise, and post-marathon disorientation or agitation and altered mental status, excessive fluid consumption motivated by dehydration fears. Exercise-induced hyponatremia presents with paradoxical weight gain, as we mentioned, during endurance events, followed by neurological symptoms, including disorientation or confusion. Critical diagnostic clue is the timing pattern. The delayed absorption of ingested water causes sudden drop in serum sodium concentration after exercise acutely. Serum sodium level below 130 usually requires immediate medical attention to prevent cerebral edema and seizures. Management of exercise-induced hyponatremia in general depends on the presence or severity of symptoms. For mild, asymptomatic or minimally symptomatic cases like bloating, mild nausea, headache, the key step is immediate restriction of oral fluid ingested. And observation until spontaneous diuresis restores sodium balance. But in moderate or severe symptomatic cases like confusion, seizures, altered mental status, coma, rapid but controlled correction of IV 3% hypertonic saline, typically 100 ml boluses repeated every 10 minutes up to 3 times or until the patient is awake, is recommended to quickly raise serum sodium by 4 to 6 millimole per liter and relieve cerebral edema while avoiding overly rapid correction to prevent also the non-ODS. Isotonic saline also or hypotonic flows are contraindicated as they can worsen the hyponatremia, which called the desalination syndrome. Athletes should be cooled if hyperthermia is present and monitored closely in an acute care setting until stable. Shifting to another medication which commonly used in ICU cause acid-base disturbances is the Propofol infusion. Starting with pathophysiology and risk factors, this usually occurs in critically ill patients requiring vasopressor support. Propofol administration exceeding 48 hours duration cause severe intracellular energy depletion and mitochondrial dysfunction, and it impairs fatty acid oxidation and cellular respiration. This promotes catecholamine-resistant vasodilation. High risk and dose exceeding 4 to 5 mg per kg per hour, associated with concurrent catecholamine administration usually, and increased risk in patients with critical illness and systemic inflammation. The patient will have high iron metabolic acidosis, which will be the main presentation, and skeletal muscle breakdown, rhabdomyolysis, and this is the second medication after the Ecstasy, which will cause rhabdomyolysis in this lecture. Also, it's arrhythmogenic, cause hemodynamic instability, sometimes cause AKI with rising creatinine. As we mentioned, elevated CK as a sign of muscle damage, breakdown, and also in the presentation of rhabdomyolysis. As we mentioned, cardiac instability, bradycardia, hypotension, sometimes cause hyperkalemia, and sometimes we have brigade-like ECG changes or what's called ST segment elevation in ECG. Propofol infusion syndrome should be suspected in any critically ill patient receiving prolonged propofol sedation who develops unexplained metabolic acidosis plus cardiac dysfunction and elevated creatinine kinase. Early recognition is crucial as mortality rates may exceed 30%. For management, immediate discontinuation of propofol is a cornerstone of management with aggressive supportive care in the ICU. Sometimes the case develops severe metabolic acidosis and should be managed by treating the underlying cause, improving perfusion, oxygen delivery, maybe considering with cautious sodium bicarb, also a pH less than 7.1, AKI is treated by renal replacement therapy. CRRT is preferred in unstable patients, both for clearance of toxins or control of associated hyperkalemia. Hyperkalemia per se may be corrected urgently by IV calcium or stabilized cardiac myocytes membranes. Insulin glucose infusions may be beta agonists or dialysis in refractory cases. Arrhythmia are common and may require antiarrhythmic therapies or pacing sometimes or advanced cardiac life support protocols. Catecholamines should be minimized if possible due to worsening myocardial stress. In refractory cases of Propofol infusion syndrome, ECMO has been used as rescue therapy. Shifting to another medication used frequently in ICU, sodium nitroprusside toxicity. It is a potent vasodilator used in hypertensive emergencies. Prolonged administration at higher dose lead to cyanide accumulation. Cyanide disturbs cellular respiration by inhibiting cytochrome C oxidase. This impairs aerobic metabolism, shifts to anaerobic pathway, results in profound lactic acid production. Vasodilatation contributes to systemic hypotension. Patients with hepatic or renal dysfunction at higher risk of toxicity. The patient will have characteristic plethoric red cherry skin coloration, progressive hypotension despite vasopressor support, which is true in MSQ and in real life. GI symptoms like nausea, vomiting, abdominal discomfort, and high anion gap at the metabolic acidosis also. Elevate serum cyanide and lactate levels. If you can measure cyanide will be conclusive, but it's not available, but lactate level will be high. Tachycardia followed by bradycardia in severe cases. CNS dysfunction like infusion, decreased conscious level. EPG showing metabolic acidosis with respiratory compensation. The diagnosis of sodium nitroprusside toxicity is primary clinical based on exposure history and the characteristic finding. The combination of unexplained lactic acidosis, distinctive cherry red skin, and progressive cardiovascular instability, as we mentioned, in a patient receiving high dose or prolonged sodium nitroprusside infusion should trigger immediate discontinuation and consideration of cyanide antidote therapy like hydroxycobalamin or sodium thiosulfate. Going to another entity called compulsive polydipsia. Okay, compulsive or excessive intake beyond physiological need is the definition of this entity. Consumption of large volumes of hypertonic fluids, hypotonic fluids overwhelm renal free water excretion capacity. Normal kidney requires solute to facilitate water excretion. Excessive free water intake dilutes extracellular component. Prolonged polyuria may impair renal concentration ability, and this is a vicious circle. Chronic diuresis downregulates aquaporin channels in collecting ducts. Psychiatric conditions often underlie compulsive water-seeking behavior. The patient will have hyponatremia, reduced serum osmolality typically below 280, dilute urine with low osmolality below 100. So both serum osmolality and urine are low. Low urine sodium concentration approximately to 120 millimole per liter. Neurological symptoms up to seizures and coma in severe cases. Frequent urination patterns like nocturia, polyuria, and observed excessive fluid intake behavior. And this will be mentioned in MSQ. And in real life, the patient will holding water bottles and frequent water fountain use. The diagnostic approach for compulsive polydipsia, which is differentiated from diabetes insipidus, is the water deprivation test, WDT. In water deprivation test, normal individuals after fasting 8 hours will demonstrate urine osmolality exceed 500 milliosmol per kg. But patients with compulsive polydipsia show impaired concentrating ability with minimal increase in urine osmolality during testing. And this is switch from diabetes insipidus, where ADH hormone administration produce significant concentration response, which will increase urine osmolality up to 600. Chronic polydipsia may permanently alter renal tubular function in chronic cases, as we mentioned, complicating interpretation of diagnostic result. As maybe the patient would be compulsive polydipsia, but with no or low effect of water deprivation test in cases of chronic polyuria and polydipsia. Okay, the management of this entity, we often see in psychiatric disorders such as schizophrenia, and the management focus on fluid restriction to prevent recurrent hyponatremia, alongside close monitoring of serum sodium and urine output. Treating the underlying psychiatric condition is key using behavior therapy, CBT, psychoeducation, medication optimization. Maybe sometimes the patient receiving anticholinergic, maybe they need just only to minimize doses or adjusting the doses. In severe refractory cases, supervised inpatient care may be needed to ensure compliance with fluid limits and calculating the urine output and the intake. In general, regular follow-up and coordination between psychiatry and primary care and nephrology can help prevent complications and the recurrence of this entity. Shifting to another entity that called acid-base disturbance, which is convulsions. Okay. The pathophysiology, generalized tonic-clonic seizures cause intense muscle exhaustion and activity. Anaerobic glycolysis occurs during seizures activity. Muscle metabolism generates lactic acid as a byproduct. It is self-limited physiological response to muscle exertion. Brain generally protected against systemic acidosis, but cerebral intracellular acidosis may occur from lactic acid accumulation in a marked degree. Seizures, hypoxia, and ischemia can trigger this process. The patient will come immediately in post-ictal period, mild to moderate lactate elevation from 3 to 7 millimole per liter, resolution typically within 1 to 2 hours after the event, increased anion gap from temporary lactic acidosis. Also, osmolar gap may be elevated. Potential concurrent alcohol presence as distracted MSQ, they will say in head of the question. With all these scenarios, the patient is alcohol intake, and he comes maybe sometimes he put osmolar gaps high to be mistaken as alcoholic ketoacidosis. Post-convulsion acidosis not requiring specific treatment, but observe the patient and repeat EPG after 2 hours to confirm resolution. Warning sign will be persistent or worsening lactic acidosis beyond 2 to 3 hours, suggest an alternative diagnosis or ongoing pathology. Differential diagnosis will be consider other causes of final if acidosis persists or clinical picture is inconsistent with recent seizure activity. Okay, going to another medication, linezolid-induced lactic acidosis. The pathophysiology and the mechanism, linezolid inhibit mitochondrial protein synthesis, impaired oxidative phosphorylation, decrease aerobic metabolism, shift to anaerobic glycolysis, increase lactate production. Accumulation of this lactate leads to high anion gap metabolic acidosis. Toxicity typically develops with subacute or chronic use from 5 to 7 days or more. Most cases reported after 2 weeks of continuous therapy. Early onset possible in patients with renal impairment due to decreased clearance may cause concurrent hematological effects, which is a clue, thrombocytopenia or anemia. Clinical features of this medication: markedly elevated serum lactate, as we mentioned, more than 4 to 5, high anion gap metabolic, but with normal ketones, increased risk in critically ill patients, higher incidence in patients with renal failure, elderly patients more susceptible to toxicity. Clinical symptoms may be in general fatigue, nausea, vomiting, tachypnea, and the patient may present with unexplained metabolic acidosis despite clinical improvement from infection. MSQ key. Sometimes they mentioned in head of questions, the patient has infection, CBC is TLC is high, and CRP procalcitonin is high. The patient, in spite of Resolution from infection still has increased lactate, but the patient is still on linezolid antibiotics, so will be the clue for that. So diagnosis primary clinical based on elevated lactate in relation to linezolid administration, exclusion of other causes. Resolution after discontinuation, consider checking serum linezolid level if available, monitor lactate trends before and after stoppage of the medication. Management involves prompt discontinuation of linezolid and supportive care until acidosis resolves. Going to another medications, which is salicylate, toxicity, and mixed acid-base disorder. In early phase of usage, primary respiratory of toxicity, primary respiratory alkalosis due to direct stimulation of medullary respiratory center. Later, higher metabolic acidosis develop from salicylate accumulation and organic acid production. Mixed disorders, simultaneous low partial pressure of carbon dioxide and low bicarbonate level. Uncoupled oxidative phosphorylation leading to increased metabolic rate and heat production. Disrupt glucose metabolism in the central nervous system, causing intracellular neuroglycopenia, which is very, very important. Impairs platelet function, leading to potential thrombocytopenia and bleeding diathesis. Leads to cerebral edema in severe cases with altered blood-brain barrier permeability. Patient will have tinnitus, hearing impairment, and vertigo, which is early and classic symptoms. Hyperventilation with tachypnea, respiratory rate more than 20. GI symptoms, which is non-specific, will be abdominal pain, neurological confusion up to seizures and coma, hyperthermia, fever from metabolic uncoupling. This is very important. Serum salicylate level more than 30 indicates toxicity, and more than 70 is very severe. A typical presentation in elderly patients may lack hyperventilation, which is very important in MSQ. Also, in young children may present with primary metabolic acidosis without respiratory alkalosis. Also, it comes in MSQ. Clinical management consideration, which is very, very important. In such cases, avoid intubation if possible. Removing respiratory compensation, the alkalosis can precipitate sudden acidosis and clinical deterioration. Avoid acetazolamide as it can worsen acidosis. Consider urinary alkalization to enhance salicylate excretion, especially when serum levels more than 40 to 50. And CNS symptoms can occur even with normal blood glucose due to, as we mentioned above, intracellular neuroglycopenia. Shifting to another medication, which is paracetamol and the non-pyroglutamic acidosis, known also as 5-oxoprolemia. This caused by accumulation of pyroglutamic acid 5-oxoproline in the body, results from disruption in the gamma-glutamyl cycle responsible for glutathione synthesis. Acetaminophen, the brand name of is paracetamol, depletes glutathione levels even at therapeutic doses. Glutathione normally provides negative feedback by inhibiting gamma-glutamyl cyclotransferase. With its disinhibition, production of 5-oxoproline increase dramatically. Accumulation of pyroglutamic acid in the bloodstream leads to high on metabolic acidosis. The patient will come with unexplained high on metabolic acidosis, normal lactate levels despite significant acidosis, normal ketones level in blood and urine, normal renal and liver function, no evidence of toxic alcohol ingestion, and elevated pyroglutamate in urine and plasma if the testing is available, and non-specific symptoms of altered mineral status up to decreased conscious level and coma with tachypnea and fatigue. Who's on high risk for this side effect or this acidosis? The chronic use of acetaminophen even at therapeutic dose is very important. Sepsis and critically ill patients, malnutrition and alcoholism or pregnancy due to high catabolic and high build for the body and energy demand. Also, the renal insufficiency, patient elderly, concurrent use of fluoxetine and the carbamazepine antibiotics. Also, this comes in MSQs as a key. In context elderly with pain conditions, sciatica with infection, but resolve it, a patient is consuming therapeutic or maybe super therapeutic dose of acetaminophen, but developed blah, blah, blah. Okay. What about management of this anxiety? Management involves immediate discontinuation of the offending drug, like any of the previous or upcoming medications, along with supportive measures to correct the underlying metabolic acidosis, like IV sodium bicarbonate if severe cases. But in acetylcysteine is often administered to replenish glutathione stores and facilitate detoxification, especially if acetaminophen exposure is implicated. Treat any precipitating factors such as sepsis, as we mentioned, malnutrition, chronic kidney disease, provide adequate hydration to support renal clearance. But in refractory or severe cases, hemodialysis can help remove accumulated acids and correct acid-base balance. Moving to another entity, acid-base disturbance from irrigation solution in surgery. Irrigation solution used during surgery can be absorbed systemically. Common irrigants include glycine, sorbitol, and mannitol solutions. These non-electrolyte solutions act as active osmoles. Glycine molecular weight 200, osmolar weight 200, and sorbitol 165. So absorption occurs during procedures including visceral perforation. Raises measured serum osmolarity, but the calculated will not be increased, just the measured. This results in increased osmolar gap and lead to dilution hyponatremia with paradoxically normal or increased osmolarity. The patient will have sudden post-operative confusion or altered mental status, seizure secondary to electrolyte disturbance according to the severity, visual disturbance, particularly common with glycine absorption, metabolic acidosis with normal lactate and ketones level, osmolar gap between above 10 to 15, hyponatremia, signs of fluid overload, peripheral edema, pulmonary congestion, hemolysis, particularly associated with water as irrigant. The management strategy in operations like TURB estimate volume of irrigant absorbed. For procedures with high absorption risk, monitor serum sodium osmolarity and mental status. Treatment is primarily supported with close monitoring and correction of electrolytes abnormalities, and in severe cases with neurological symptoms, consider possibility of cerebral edema and manage accordingly. Going to another medication side effect and acid-base disturbance, propylene glycol toxicity. Okay, the intravenous benzo, particularly diazepam and lorazepam, are formulated with propylene glycol as an solvent. Accumulation occurs with high dose or prolonged infusion, especially more than 10 mg per day for more than 2 to 3 days. Metabolism via alcohol dehydrogenase pathway leading to toxic metabolites. Late onset osmolar gap after 3-4 days of usage distinguish it from ethylene glycol toxicity, which will be early osmolar gap. Concurrent exposure for multiple medications containing propylene glycol has an additive effect. Impaired clearance and renal dysfunction exacerbate toxicity. A patient will the high-risk patient will be the prolonged ICU sedation requiring high-dose lorazepam, pre-existing renal and hepatic dysfunction, sepsis or septic shock, increased metabolic vulnerability, multiple medications containing propyl glycol like phenytoin and nitroglycerin. What he will be presented, the propylene glycol toxicity patients. High metabolic acidosis is the hallmark lab finding. Elevated osmolar gap will be prominent. Late central venous system vibration beyond expected sedative effect of propylene of the benzo, and AKI, some cases, seizures, paradoxical for benzodiazepine administration, hypotension, which is resistant to vasopressor, which is key also in MSQ, normal benzo levels, toxicity from solvent, not the medication. Management tips for this entity: switch to midazolam, the water-soluble benzo without propylene glycol, and discontinue all medications containing propylene glycol when possible. Supportive care with fluids and acid-base management. Consider hemodialysis in severe cases with significant renal impairment. Shifting to another toxins, which is very important in real life and also in MSQ, the ethylene glycol poisoning. Sources and pathophysiology comes from antifreeze, coolant for automotive engines, most common source, and de-icing fluids, brake fluids, and necessary solvents. This metabolized by alcohol dehydrogenase, which is a very important role in this entity to glycoaldehyde. Further oxidation produces glycolic acid, glycoxylic acid, and oxalic acid. The toxic metabolites cause mitochondrial dysfunction and cellular damage. Calcium oxalate crystals formation leads to tissue injury and hypocalcemia. Risk context: automotive product access, workplace chemicals, and intentional ingestion in some scenarios. The lab pattern with 3 red flags: high enantium antabolics from glycolic acid accumulation, elevate osmolar gap from unchanged ethylene glycol in early stages, the parent toxins, then normal or low lactate and absent ketones, which will be differentiating factors. Diagnostic clues and clinical periods: calcium oxalate crystals, envelope or needle shape in urine microscopy, hypocalcemia and serum chemistry panel, fluorescent urine under Wood's ultraviolet lamp if antifreeze contains fluorescent, serum ethylene glycol level, confirm diagnosis if it's available. The patient will have 2 clinical presentations, early and late. Early in first 12 hours, CNS depression similar to alcohol intoxication. Then nausea, vomiting from gastro irritation, significantly elevated osmolar gap. The parent compound present, as we mentioned initially, a normal arterial pH before metabolite accumulation. Then the late presentation from 12 to 48 hours. The patient will come with severe metabolic acidosis from glycolate accumulation, as we mentioned. Hypocalcemia as oxalate bind calcium forming crystals. He will have flank pain and hematuria from renal crystal injury. Seizures and coma from neurotoxicity and acidosis, which may be prominent. Oliguria and anuria from acute tubular necrosis in some cases. So we'll have sick apparent patient, the plus altered mental status, anion gap acidosis, plus osmolar gap, and calcium drop, oxalate crystals, AKI. So you should suspect ethylene glycol poisoning. Important point: lactate gap may occur. Glycolate may be mistaken for lactate on some analyzers, causing falsely elevated lactate readings with normal EBG results. So what we will do is management. The management is focused on rapid inhibition of alcohol dehydrogenase to prevent metabolism from the parent to toxic acids, using either fombizole, the preferred one, or ethanol if fombizole is unavailable. Adjunctive thiamine or pyroglutamic are given to enhance non-toxic metabolic pathways, particularly in chronic alcohol users or the malnourished. Aggressive IV flows are initiated to support renal perfusion, and hemodialysis is indicated for severe metabolic acidosis, renal failure, or electrolyte disturbance, or high ethylene glycol levels, as effectively removes both the parent and the toxic metabolites. Early treatment or monitoring of acid-base disturbance, anion osmolar gap, and renal function is essential to reduce morbidity and the high risk of mortality. Shifting to another toxins, which is methanol. Methanol toxicity. Sources and pathophysiology: windshield washer fluid, the most common source of exposure. Paint thinners, industrial solvents, incubation exposure. homemade alcohol moonshine, common in prisons, canned heat products like accidental ingestion, methanol metabolized to formaldehyde then to formic acid. Formic acid causes inhibition of cytochrome oxidase. Metabolic acidosis develops as formic acid accumulates. Retinal toxicity, very important, cause characteristic visual disturbance, which is snowfield vision, blurred vision or photophobia, progressive vision loss, potential permanent blindness, very, very important condition. CNS, headache, confusion, seizure, and coma, like the previous presentation of ethylene glycol, GI or general, respiratory beta-capnia, compensatory for acidosis, and the late presentation is a strange thing here. Symptoms often appear after 12 to 24 hours post-ingestion. Advanced imaging may show bilateral putaminal necrosis. Classic lab pattern like high negative acidosis plus elevated osmolar gap and visual symptoms, you should suspect methanol toxicity. Serum methanol more than 20 are considered toxic, but testing may not be readily available. Note that the osmolar gap is elevated early when methanol is present, but decrease as methanol is metabolized to formic acid, while the anion gap increases as formic acid accumulates. Some analyzer may mistake for lactate, creating again what's called lactate gap. Okay, what about management? While the core antidotal therapy and dialysis principles are the same like ethylene glycol, as we mentioned previously, methanol management adds folinic or folic acid to specifically address formic acid mediated optic nerve toxicity, which is very important in such cases. Okay, moving to another thing is frequently seen in ICU, the TPN. The TPN contains glucose, amino acids, electrolytes, lipids, and sometimes alcohols and glycerol. Increase measured serum osmolarity without affecting osmolar gap normally. Often administered in fluid-restricted regimens leading to concentrated urine. High glucose content may cause water shift from intracellular to extracellular space. Hyperglycemia from TPN cause translocational hyponatremia. Large volumes infusion can result in dilutional hyponatremia. Overly hypertonic solutions may stimulate ADH release also. The patient will have hyperchloremic metabolic acidosis from excessive chloride content in TPN. High protein amino acid load increased acid production, sulfates and phosphates. Thiamine deficiency can impair pyruvate metabolism leading to lactic acidosis. Sepsis during TPN administration can cause secondary lactic acidosis also. Renal dysfunction, impaired excretion of acid load from TPN components. Lipid emulsions containing glycerol or MCT may generate ketones. Underfeeding during TPN can promote catabolism and metabolic acidosis. Always check osmolarity and TPN of TPN solutions before administration, because if it's more than 900, will require central venous access. And in unexplained concentrated urine with rising creatinine, review TPN osmolar load and fluid balance. When monitoring sodium levels in patients receiving TPN with hyperglycemia, calculate corrected sodium to account for glucose-induced water shift. Moving to another entity called potomania. The pathophysiology. Kidney requires minimum solid loads like urea, sodium, potassium to excrete free water effectively, like we said before. Beer consumption provides us water with minimal electrolytes and protein. Low protein intake results in reduced urea generation, limiting solid availability. Reduced solid load impair renal free water clearance capacity. Water retention leads to dilution hyponatremia despite normal kidney function. Condition exacerbated by chronic malnutrition and poor dietary intake. Limited solid excretion, typically below 10, versus the normal from 600 to 900. The patient will present with classic hypo pattern in lab finding, severe decreased serum sodium, usually below 120, decreased serum osmolarity below 270, low urine sodium excretion below 20, as body average sodium preserve it. Urine osmolality lowish from 100 to 300, but not maximally diluted. Symptoms include confusion, seizures, and maybe cerebral edema. Diagnostic includes history of chronic alcoholism, high beer intake, and poor nutritional status, normal kidney and renal function despite electrolyte abnormalities. The key clinical consideration here, why not primary and acidotic disorder, this is hyponatremia. Patient may develop concurrent alcoholic ketoacidosis or lactic acidosis from alcohol binge or sepsis. Correction of this hyponatremia must be cautious to avoid ODS. Treatment focus on fluid restriction, gradual sodium correction, and nutritional support. Differential diagnosis should include SIADA, cerebral salt wasting, or adrenal insufficiency. Going to another entity called tea and toast diet syndrome. Extremely low dietary solid intake, primarily seen in elderly or malnourished patients, minimal protein and salt consumption, diet consisting mainly of tea and toast or minimal food, reduced renal solid load impairs the kidney ability to excrete free water. This is a rule, as we mentioned before, in many entities. Kidney requires adequate solid sodium or urea to excrete water effectively, while insufficient solid free water build up circulation, diluting serum sodium. ADH may remain mildly stimulated due to volume depletion or in case of nausea or cortisol deficiency. Patient will have decreased serum sodium below 135, low serum osmolality below 275, confirming hypoosmolar hyponatremia, the true hyponatremia. Urine osmolality often more than 100, despite the low urine sodium, which will be the clue to suspect tea and toast diet syndrome. The low urine sodium below 120 suggesting RAS system activation to preserve the sodium. Blood urine nitrogen creatinine ratio may be slightly elevated, suggesting dehydration. Clinical volumetric may be euvolemic or mildly hypovolemic. Who is in risk for this syndrome? High risk population will be elderly, socially isolated patient, those with limited access to proper nutrition, psychiatric patients, prisoners. Red flags, elderly in tea and toast, diet plus diuretics are at extremely high risk for severe hyponatremia. Differential diagnosis, consider coexisting SIADA or adrenal insufficiency if correction is ineffective. Treatment focus on gradual sodium correction plus nutritional rehabilitation with careful protein and salt reintroduction. Going to the D-lactic acidosis in short bowel syndrome. It's a rare complication, but it happens, and you should suspect it in some circumstances and scenarios. Malabsorption of carbohydrates in small intestine, unabsorbed carbohydrates reach colonic bacteria, bacterial fermentation produce D-lactate isomer, not L-lactate. Humans lack sufficient D-lactate dehydrogenase enzyme, which is the problem for us. D-lactate accumulates, causing metabolic acidosis, neurotoxic effect on CNS, requires colon in continuity with small intestine. The patient will have episodic symptoms occurring after high-carb meals, neurological symptoms, confusion, slurred speech, ataxia. Patient will appear drunk without alcohol consumption. Will also have high and high metabolic acidosis, normal lactate levels on standard lab testing, normal osmolar gap, which will differentiate it from toxic alcohol ingestion, and negative urine ketones, temporal relation between carb and intake and symptoms. The key diagnostic consideration here, diagnostic triad of high and negative metabolic acidosis plus neurological symptoms and normal lactate in patients with short bowel syndrome should prompt consideration of lactic acidosis. The most important is diagnosis requires specific D-lactate assay, which is sent out test in many laboratories, maybe not available in many countries. The treatment involves carb restriction plus antibiotics to reduce colonic bacteria plus bicarb supplementation for severe acidosis pH less than 7.1. Moving to alcoholic ketoacidosis, which is similar to beer butamania. Chronic alcohol consumption leads to poor nutritional status and depleted glycogen stores. Ethanol metabolism increased NAD-NAD ratio, inhibiting gluconeogenesis. Starvation and alcohol withdrawal stimulate counter-regulatory hormones like glucagon and cortisol, increased lipolysis and free fatty acid release from adipose tissue, liver convert fatty acid to ketone bodies, beta-hydroxybutyrate, the predominant one, ketosis and metabolic acidosis occurs even with normal or low blood glucose, volume depletion from vomiting, and poor intake diuretic effect of alcohol. The patient will present with chronic alcoholic with recent binge followed by 1 to 3 days of vomiting and food abstinence. Abdominal pain and nausea, vomiting, rapid breathing, tachypnea, agitation can happen. Often alert mental status, unless complicated by hypoglycemia. Signs of hydration like dry mucous membranes, decreased blood pressure, elevated heart rate. The patient blood glucose may be low or normal or slightly elevated. High on-anger metabolic acidosis pH, potentially normal due to respiratory compensation. Ethanol level may be low or undetectable at presentation despite recent consumption, which is very important in SQTIP. Clinical period for this, serum ketone measurements may significantly underestimate the severity of ketosis because standard nitroprusside test dipsticks primarily detect acetoacetate but not beta-hydroxybutyrate, which predominates in alcoholic ketoacidosis. The osmolar gap may be slightly elevated even with ethanol is no longer detectable. Treatment focus on fluid resus with dextrose-containing solutions and careful electrolyte replacement, especially potassium and phosphate. Going to metformin-associated lactic acidosis, which is known as MALA. Inhibition of mitochondrial complex by metformin leads to decreased oxidative phosphorylation, increased lactate production, reduce hepatic gluconeogenesis, decrease lactate clearance. Metformin accumulates in renal failure, worsening lactic acidosis. Lactate will be more than 5, pH less than 7.35, with elevated anion gap as typical presentation. Which is high risk for this MALA? Estimated far below 30, which is absolute contraindication to use, AKI or volume depleted patients, heart failure, sepsis, hypoxia, radiocontrast exposure, alcohol abuse, or liver dysfunction. The patient will present with non-specific symptoms like nausea, vomiting, abdominal pain, constant breathing, metabolic acidosis compensation, hypotension, confusion, lethargy, can progress rapidly to shock or MOF. What's the guidelines from ADA or KDIGO updates? If GFR more than 60, give full dose, okay. Below 60, continue but monitor renal function more frequently. Below 45, use with caution. Maximum dose 500 mg BID. There is debate of to start or not to start, but if the patient is on, just make the maximum dose 500. If the patient GFR below 30, it's contraindicated. Stop if he is taking and don't initiate. If the patient has AKI or unstable renal function, withhold temporarily. And the rule is withhold metformin in 6 days before and for 48 hours after iodinated contrast, especially if GFR below 60 or risk of AKI. Clinical periods, we should know that metformin is not inherently toxic. Risk increase only in accumulation or stress states. Lactic acidosis with metformin is rare, less than 10%, 10 patients per 100,000 patients, but high mortality recorded approximate to 50%. Monitor renal function before initiation at least annually, more if the patient is CKD or elderly. Don't forget to check lactate and EPG if the patient on metformin is sick or hypotensive, as we mentioned before. Shifting to a very important entity, the diabetic ketoacidosis, the most common acidosis presentation. Clinical DKA often presents with non-specific symptoms that progress over several hours. Patient typically report polyuria, polydipsia, weight loss, fatigue, and weakness. As the acidosis worsens, symptoms escalate to nausea, vomiting, abdominal pain, and sometimes altered mental status, ranging from mild confusion to coma, depending on severity. Classic findings: cosmal respiration, deep rapid breathing as compensatory mechanism to metabolic acidosis. Some patients may have fruity or acetylene-like breath, odor due to exhaled ketones. Abdominal tenderness can be misleading and mimic surgical abdomen. Patient will typically has high metabolic acidosis, from beta-hydroxybutyrate or S2-acetate, respiratory alkalosis as a compensation. Gap analysis can help detect concurrent metabolic disturbance like metabolic alkalosis in case of vomiting. On examination, signs of hypovolemia will be prominent: dehydration, including dry mouth, membranes, poor skin turgor, sunken eyes, tachycardia, hypotension, hypothermia may occur in severe cases. Neurological cyst is variable and correlates with the degree of acidosis and osmolality. Children and adolescents are particularly vulnerable to cerebral edema, which is the most feared complications of decay. What is the diagnostic criteria according to ADA? Glucose should be more than 250, except if the patient is receiving SGLT inhibitors because of euglycemic related ketoacidosis, pH less than 7.3, bicarbonate less than 18, positive serum or urine ketones, and gap more than 12. Common pitfalls to avoid in this entirety: starting insulin before fluids. This will increase risk of shock and worsening acidosis. So we should start fluid at a first step. Second part, ignoring potassium levels. Always correct potassium before insulin because potassium will cause more drop of potassium shifting to intracellular space. Missing mixed acid base. Usually use delta gap or evaluate for coexisting normal or high chloride acidosis or even metabolic acidosis. Stopping insulin at glucose below 250. No, you just must continue insulin until anion gap normalizes. Using pH as a sole indicator of recovery. No, track anion gap and ketone clearance will be more safer. Shifting to starvation ketoacidosis. Okay, in prolonged starvation or fasting, usually more than 48 hours, glycogen stores and liver muscles depleted, lipolysis increase, free fatty acids oxidize in liver, ketone bodies reduction, S2-acetate or beta-hydroxybutyrate. Ketones serve as alternative energy, especially for brain and heart. Starvation ketosis is physiological, so not toxic, usually mild to moderate acidosis. Patient will present with nausea, vomiting, mild abdominal discomfort, dehydration. Typically occur after fasting by 2 to 3 days, as we mentioned, little or no intake. Fruity breath acetone in some patients. Patient is alert, no confusion, which will differentiate from DKA. Will present with high anemia metabolic acidosis, but typically mild. Ketones are organic acid, increase anion gap, compensation by respiratory alkalosis. Also important, beta-hydroxybutyrate is not detected by some urine stick. They only detect the S2-acetate, as we all know. Serum ketones measurement perfect. Again, lab finding, glucose normal or slightly low, but not below 60. Ketones positive, urine and serum. Beta-hydroxybutyrate elevated. Anion gap mild to moderate elevation. pH normal or mildly low, usually more than 7.3. Bicarb mildly decreased from 12 to 22. Osmolar gap is normal. Okay, this is a comparison between starvation ketoacidosis and DKA and alcoholic ketoacidosis. Regarding acidosis, will be mild in starvation, will be severe in DKA, will be moderate in alcoholic ketoacidosis, and mental status will be normal in starvation, but altered in DKA and variable in alcoholic. Also, ketones will be high in both DKA and alcohol ketoacidosis, but be mild to moderate in starvation. Response to carb will be improved dramatically with starvation, but required insulin in DKA, and alcohol ketosis need thiamine and glucose. Shifting to another entity called isopropanol toxicity. What is the source? Rubbing alcohol, hand sanitizers, mouthwash, antifreeze, solvent products. Ingestion is the most common route. Inhalation may be dermal, very rare. Toxic dose as little as 20 to 50 ml of 70% IPA can cause symptoms, but more than 240 may be lethal. Pathophysiology: IPA is metabolized by alcohol dehydrogenase to acetone. Acetone causes depression and osmolar gap, but acetone is not acidic, so no acidosis in this entity. Unlike methanol or ethylene glycol, IPA is not converted to toxic acids. So what's the clinical presentation? CNS separation like ethanol but stronger. Early dizziness, headache, slurred speech, later stupor, coma, respiratory depression. GI symptoms may be up to gastritis to causative effect of IPA. Classic signs, fruity odor, breath from a stone by definition. Hypotension, bradycardia from vasodilatation and myocardial depression. Hypothermia from peripheral vasodilatation. And rare, there is rhabdomyolysis and AKI and hemorrhagic gastritis. pH usually, as we mentioned, slightly acidic, anion gap normal, not elevated, osmolar gap increase, which is key feature. Serum ketones positive for acetone, not beta hydroxybutyrate. Serum IPA acetone confirmed that is available. So there is comparison between isopropanol, methanol, and ethylene glycol. All of them has increased osmolar gap, but the IPA, as we mentioned, has normal anion gap. CNS separation is very profound in propylene and isopropanol toxicity. Visual symptoms is very prominent in methanol. Renal failure is prominent in ethylene glycol. Acid-base disturbance, normal anion gap or mild acidosis in isopropanol, but may be accentuated with severe anion gap acidosis in methanol and ethylene glycol. Thank you very much for listening. I think we mentioned maybe up to 25 acid disturbances in common practice. I hope it will be helpful for each of you. And see you in the next webinar, inshallah. Thank you so much.